Thank you, sir. Good afternoon to you all. First, I like to convey my gratitude to the CCP for giving me this chance to perform in this stage. So today, now I'll move into my topic, neuroplasticity, the amazing power of brain to rewire. Actually, neuroplasticity is the scientific basis of neurorehabilitation. That is, our all rehabilitation interventions are mainly based on this neuroplasticity. Actually, it was not a long time ago that we all thought our brain has no plasticity or no any capability of adaptability, especially following our period of adolescence. But during last decades, it has been found and proved by the neuroscientists that it is not true at all. And they have found that our brain is adaptable and it is changeable, and also it can be rewired throughout our lifespan. So if I simply say neuroplasticity is the ability of nervous system to undergo structural and also functional changes in response to new experience. It is hugely experience dependent. Hence, it's very important for the application of rehabilitation interventions like specific exercise training and also cognitive training. And the other interesting thing is this neuroplasticity is not only limited for our brain cortex, hence we also can apply it to the spinal cord injuries and also peripheral neuropathies and even in limb amputations also. But the thing is, our most available researches and also trial evidences are based on mainly the stroke with the highest prevalence of stroke in our world. If we are moving to the natural neuroplasticity of our brain, here in this graph, we can see they have shown how the functional recovery is improving with time following stroke. So here it has plotted the Fugl-Meyer motor score to measure the functional score of a patient, of people following a stroke, which is plotted against the time. So we can clearly say even following a severe stroke, there is a considerable improvement of the functional score of people, even without any intervention or treatment. So this is due to the neuroplasticity. This is actually it is due to natural neuroplasticity that we human brain owns. Still, there is a significant gap from this maximum functional outcome to the baseline level. So this is here we are applying neuro rehabilitation interventions to achieve targeting to achieve the maximum functional outcome for these people. This is the biology of brain recovery following a brain insult. That means here actually it has shown against following a stroke. In this this period showing following acute brain stroke, the cell death is maximum following the initial period, and a little later there is a significant rise of neuroinflammation, and it comes to a maximum and start to decline with time. And you can clearly say when the neuroinflammation is starting to decline, there is another line is rising here, which implies neuroregenerative process. So this is the time that we consider our neuroplasticity mechanisms are started, and we can if we start the intensive neurorehabilitation interventions involving this time period, it is said that we can keep a good hope to achieve and restore the functions that has been lost due to the impairments caused by the brain insult. This diagram shows what are the main and common mechanisms which are undergone during the time period of neuroplasticity. If we start exercises, may even goal-directed or aerobic exercises, there are multiple mechanisms activated inside the brain. Increased synaptic strengthening and increased improving the for the improvement of brain health. So these mechanisms altogether try to strengthen the circulatory system in different brain regions, and finally, they help us to improve the functional outcome of the patient in different aspects involving the motor, cognitive, and also motivation. If you think, move into the how does neuroplasticity work, actually, it has, we know that brain has numerous neural pathways that has already established to activate with each activity, feeling, or thinking. But when we start a new task, new learning, or new feeling, brain can form new neural pathways. And if we do that new thing repeatedly, brain has the capacity to get used to that and new pathway, and it tries to establish it as a new habit. So mainly the two types of plasticities has been identified. It can be a functional or structural. The first diagram actually shows how the functional plasticity happens following a brain insult. It has the capacity to shift their responsibilities from damaged brain areas to the undamaged brain areas. That is the functional plasticity. And in structural plasticity, even after a damage, still the undamaged neurons try to compensate those neuronal pathways responsibilities through the new neuronal or collateral formation of the sons or dendrites. So, neurorehabilitation is actually a evidence-based medicine, which means it is proceeding as a it is proceeding according to the each individual's current status, correlating with our clinical judgment, also using the patient's values and preferences altogether, combined with relevant available scientific evidences. We can show the outcome of the results of neuroplasticity with image evidence too. Here, here we can see a functional MRI showing in the yes, image B showing functional MRI prior to starting rehabilitation, and the C image is showing the functional activity of brain has how it has improved after completing rehabilitation interventions. So we can say actually neurorehabilitation is applied neuroplasticity. So it's better to know the principles of neuroplasticity, which is utilized to develop neurorehabilitation interventions and how they are applied in our rehabilitation processes when we are managing our patients. So, Kleinman Jones has come out with 10 principles of neuroplasticity, which are used commonly in our rehabilitation interventions at the moment. Those are, if I list it out, it was said as use it or lose it, use it and improve it, and also specificity, repetition, and intensity, time, salience, age, transference, and also interference. So I will go through with several principles which has listed out earlier, because all these principles are important and our all interventions are based on these principles. Basically, this use it or lose it mean actually when we use when our neuronal pathways get stronger and stronger as much as we use it, and if we are not using it, with time, it tends to get weakened and fade away with time. And use it and improve it means as much as we use it, we can make strong our neural pathways. So keep practicing is very important in neurorehabilitation interventions. Specificity means we have to undergo and start special neurorehabilitation training process. Specific that training process should be specific to the activity we are targeting to achieve. And also age matters because neuroplasticity is found to be very efficient and has a very successful in younger brains compared to the elderly people. But still, even how old the brain, still there is a capacity to learn and relearn. So the plasticity is persisting in a baseline level throughout our lifespan. But it can be different, the outcome can be different. And the time, that is the most important, I think, here. Our brain is in a special situation just right after a brain injury, which provide a critical time window, which found to be the therapies are more effective. So in this graph, the red line shows how the brain functions suddenly drop following a brain insult, and it slowly, then later on, slowly increasing. With that, the blue line here shows the neural plasticity, which has been on a baseline stage, is suddenly start to rise following this brain insult, and then it slowly begin to decline. So this area and this time period, which is having a highest neural plasticity, it is the best time to start on neural rehabilitation interventions. And it has been found when we start at the intensive rehabilitation interventions during this time, it is more effective, and we can expect a successful and very very successful functional outcome for the people. But still here, we can try as plasticity is maintained in a considerable amount in this sloping area also. Here, brain recovery, this is the, again, after a stroke, it shows how the upregulation of growth promoting factors and downregulation of growth inhibiting factors occurs, how it changes with time. Here in the upper half, there is a significant rise of upregulation of growth promoting factors, and the plateau is maintained. Highest level is here. And also the downregulation of growth inhibiting factors, showing the lower half, there is minimal amount of growth inhibiting factors are found here. So it is considered that this period as the critical period of rehabilitation interventions to be started and carried out for a targeting when we target the maximum outcome for a patient. So in our practice, actually we consider the most important period is to start active intensive rehabilitation just the 1 month after the ischemic stroke event, but still for the up to 3 months, we are considering that we still have a chance. So further regarding the best timing, most of you may have heard on AWARD, a very early rehabilitation trial, which said the initiation of high-intensity rehabilitation interventions very early, that in less than 24 hours time, give a negative outcome for a patient in 3 months' time compared to the usual care. So that's why still we are not recommending intensive rehabilitation interventions for people who need support to sit out of bed, stand or walk within the first 24 hours. But generally, we consider and it is recommended that all stroke patients should commence out of bed activities within 48 hours unless contraindicated. But now American Stroke Association has recommended that even initiation of rehabilitation is still very important even in the very acute period following a stroke. That's because that we can, when we are initiating rehabilitation, actually we can educate the patient or the caregiver or the caring health staff we can educate them regarding the correct position and the importance of turning, frequent turning, and also the correct methods of mobilization and transfer in this patient to minimize the complications which can be developed in the later time. Most possibly, the pressure ulcers and also spasticities and contractures can be easily prevented with this proper guidance. So next, I will go through with rehabilitation interventions, which has based on neuroplasticity, neuroplasticity principles, which I described earlier. I will quickly go through these interventions. These all interventions are evidence-based and has shown a good outcome for, especially for the stroke patients, as they give a good, efficient outcome for these stroke patients, and also not only for the stroke patients, any neurologically impaired patients, we can apply these things and have a good outcome. CIMT mean actually it is a constraint induced movement therapy. It is a rehabilitation strategy with a behavioral approach. Here you can see it can be applied for the adult and also pediatric population. Here restricted arm is the non-affected arm, and by that what we are doing is we are forcing the we are making the patient to use the affected arm for repetitive task-oriented and intensive activities, and then trying to stimulate the brain for the functional improvement. And our rehabilitation interventions are always task-oriented, because it has found that interventions are very successful when those training and targeting functions are meaningful to the patient. And mirror therapy, again, very easily performable low-cost therapy here. Again, it has a very proven benefit, especially in the post-stroke patients involving the upper extremity impairments. Here, what we do is we have kept the unaffected arm in front of a mirror, and the affected arm is behind the mirror. And here, when the person performing activities or any performance from the unaffected arm, he get the illusion. When he see the mirror, he get the illusion of as he is performing and actively moving his affected arm. So again, it's a trigger for neuroplasticity. And mental imagery is again another method, cognitive strategy. We are triggering the motor functions through the imagination. Here, the patient is asked to imagine as he is moving and performing activities with the affected arm, but not physically doing that. Through the imagination, we are trying to improve the functional improvement. And functional electrical stimulation is a method to stimulate the low motor neuron levels, lower motor neurons, with the electrical current to activate paralyzed muscles. Here we perform that. And PNF, again, proprioceptive neuromuscular facilitation, is a stretching technique, and it has found there is a significant rise of brain-derived neuronal factor levels, which has a good effect for the neuroplasticity, especially in post-stroke rehabilitation. And here are again, those are the main conventional rehabilitation interventions. New innovations, there are multiple emerging evidence involving the neurorehabilitation field. There are non-invasive brain stimulation techniques with direct current stimulation and also magnetic stimulation. Here we can stimulate the specific brain area with a direct current. And brain-computer machine interface, again, here we use neural activity to directly control external devices like these. And robotic exoskeletons, those are powered exoskeletons or wearable robotic units which are controlled by computer boards to restore lost stability of locomotion. Here are some examples, especially proved benefit in spinal cord injuries who are coming with paraplegia and also the upper extremity impairments to regain the locomotion and functional level. And virtual reality is a latest method which we in this immersive virtual reality method, we create a 3D enriched environment for the patient with a full of multi-sensory stimulations to give him a maximum stimulation for the brain to improve the neuroplasticity, finally to improve the functional outcome. So with these techniques, let's move. Think now whether is this rehabilitation always successful? Actually, it depends. The recovery time and outcome always different from person to person. Some may recover fully, while some may remain with long-term disabilities, even rehabilitation completely done. According to the American Stroke Association, people who had a stroke and completed rehabilitation, there are around 40% were remained with limitations for years, even in 6 months, and it has found 40% were remained with moderate to severe impairments, and still 10% needed continuous nursing care. So it depends. It depends in many factors. The outcome can be patient factors like the complexity and cognitive impairments, neglection, motivation, like, and also organizational factors and also rehabilitation strategies that are carried out. So there is still a very huge gap between the research evidence and practice. When you come to practicing these interventions, there is so many barriers that we have to encounter. Future directions, still the neurorehabilitation field is improving with new innovations and technologies. There are new innovations and researches are still ongoing with gene overexpressions and using of neuronal stem cells, neural stem cell transplantation, and also several pharmacological methods too. So here I would like to show you the researches which are carried out with time, and like the mirror therapy and CIMT are now very closer to ready for the broad clinical applications. Actually, we are currently using those things, and still many more to come and to come in our future in rehabilitation field to be used to improve our rehabilitation interventions and finally our patients' functional outcome. So we have a new hope, especially for the stroke patients after managing the acute phase of stroke with the thrombolysis, medical or surgical, and then the stroke patients when they are moving into the subacute phase or chronic phase, the only therapy what we have is neurorehabilitation. So we have, if we are improving these techniques and if we are improving the awareness of the people and also the other people involved in the health sector, we can, I think the patients who are suffering from disabilities can gain a much functional outcome rather than remaining with the disabilities throughout their lifespan. So with the future innovations and future new findings, it will be more helpful for these patients following stroke. So it is very important. The message is to it's very important when to start rehabilitation and what are the interventions that we have to apply. So I would like to, with that, I like to conclude my presentation. So I like to thank my current supervisor, Dr. Dominda Abesinghe, and also other consultants involved in my rehabilitation field and rheumatology field, including Dr. Dominda Munidas, Dr. Gunendrika Kasturiratne, and also Dr. Chamara Jayatunga, and also my previous trainers, Dr. Suresh Mendis, Dr. Anand Chanag, and also Dr. Harendra Karunatilaka, also to Dr. Upul Dissanayaka. Actually, without those personals, I would not be here. And also my gratitude to my all colleagues and also to my family. Thank you so much.